tumors. Yay. Yeah. Okay, so lung cancers. There's two types. There is small cell and there is non-small cell. Somebody was being extremely creative when they were coming up with these names. Who can tell me what a paraneoplastic syndrome is? That you should have looked up when you were doing your reading. Yes, Kate? Paraneoplastic syndromes are when tumors secrete hormones that they're not supposed to secrete. Because, you know, your pituitary gland secretes antidiuretic hormone. Some cancers will secrete antidiuretic hormone. They're not supposed to do that. So you have increased levels of ADH and you develop syndrome of inappropriate antidiuretic hormone. Some tumors will secrete parathyroid hormone. So you will become hypercalcemic. Some will create Cushing's disease. Some tumors will secrete insulin. So patients will have problems with glucose control. So not only are you getting the signs and symptoms and all the other fun stuff that comes along with that tumor in the lung, but that tumor is also secreting things that are affecting the hormonal balance for the entire body. So small cell lung cancers are particularly nasty when it comes to those types of paraneoplastic syndromes. The non-small cell lung cancers can be squamous cell, which are the cells that line the inside of the lung, adenocarcinoma, which involves that glandular tissue of the lung, and then the extremely creative type called large cell, which can be particularly virulent. Non-small cell lung cancers are staged using the TNM staging that you learned about in Nursing 200, right? So what does the T stand for? Tumor, so the number of tumors. N, node involvement, has it spread to the lymph nodes. And M, metastases. If you need a review of that, look in Chapter 6. Talks about TNM staging. So lung cancers, risk factors, leading cause of death, cancer deaths for men and women. 80 to 90% are related to cigarette smoking, and 3,000 a year roughly due to secondhand smoke. Women are having more incidences of lung cancer because of that generation of women that, you can have it all with Virginia Slims, back in the 60s. So a lot of women of, my older sister's generation, because I wouldn't know about the 60s, were heavy smokers and are now suffering from lung cancer. What are some of the other types of exposures that can cause lung cancer? Family history, environmental exposures. What's that? Occupational. What else?
Poor habit of not eating fruits and vegetables.
Right, so poor diet can make you predisposed. Asbestos. A lot of our elderly men who worked in factories back before they realized how carcinogenic asbestos was are developing lung cancer. Radon or other radiation types of exposures can cause lung cancer. And then genetic mutations, familial genetic mutations or mutations of the lung cells based on their exposure to certain carcinogens. So what do we assess? What are the signs and symptoms of that patient with lung cancer? What do you expect to see? Shortness of breath. What else? Chronic cough. But most smokers have a cough. So what are you going to ask them? Has it changed? Is it different? Are you bringing up a lot of sputum? What color is it? Bloody sputum in particular. Patients with lung cancers can develop pleural effusions. What is that? Fluid accumulates in the pleural space. And I'm going to show you, I've got a video that talks about, when we talk about chest tubes, that's going to show you what that pleural space looks like and how pleural effusions develop. But lung cancers can really create a lot of drainage and effusion into the pleural space. And as the patient becomes more, goes more into the terminal stages, more and more of that fluid accumulates. Now, has anybody had a patient that's had a thoracentesis? Yes. How much did they take off of that patient?
Over a liter.
Over a liter. The normal amount of fluid that should be in the pleural space is 25 milliliters, which is less than a med cup. So how uncomfortable was that patient before they took off 1,000 times, you know, that? What diagnostics are we going to do for lung cancers? Chest x-ray. What else? Bronchoscopy. CT scan. Biopsy. Needle aspiration. Sputum for cytology, because many times patients will be coughing up sputum. You can send that to the lab and they can detect cancer cells. Same thing when they do the thoracentesis and pull off some of that pleural effusion. They can check that for cytology, see if there's any cancer cells. So now we talk about treatments. How do we manage them? We have surgical treatments for, that are effective with some lung cancers. What is a segmentectomy? What did they remove? A part of the lung, and that's more on the internal area of the lung. So a segmentectomy could also involve a bronchus or part of the bronchus, a pulmonary artery or vein. So the segmentectomy is for those more interior localized cancers. A wedge resection is what? More of the exterior parts of the lung, where they remove a chunk of the lung that has the tumor. How about a lobectomy? They remove a lobe of the lung. What about a pneumonectomy? The entire lung. And these can be obviously very extremely invasive procedures when you get to the point of taking out you know, a lobe or an entire lung. But many of these other types where they're doing a wedge resection in particular, they can use what is called VATS, video-assisted thoracoscopic surgeries. And that's where it's almost like doing a laparoscopy, only they do it in the chest. And they go in with small incisions and remove the tumor. Radiation can be used to treat lung cancers. So what kinds of side effects do you think the patient would have with radiation based on the part of the body that is being radiated? Skin irritation. So what are you supposed to teach them about if they develop a rash from the radiation? Right, but if it was an NCLEX question, you're not gonna turf it off to the radiologist. But if the patient says, well, I got this this cream that this homeopathic physician gave me, is that okay to put on that? No, unless the physician has prescribed a particular cream, you should just teach the patient to keep it clean, wash it with soap and water, keep it dry, and avoid being out in the sun, because the sun, the UV rays, can aggravate that rash. If the patient has radiation to the chest area, then they could have damage to their ribs, because radiation can create, can weaken the bones and cause pathological fractures. So we have to be watching that patient very carefully for any kind of bone weakness. What's xerostomia? Dry mouth. So we need to then, and oftentimes when patients are being irradiated in this area, the head and neck area, they develop dry mouth, they lose some taste sensation. All of those can be very uncomfortable for the patient. Patients in late stages can have damage to the esophagus and narrowing of the esophagus because of the radiation damage. Chemo is going to be a treatment of choice for small cell lung cancer. And for non-small cell, it's usually chemo in combination with surgery. So many times with chemo, as it relates to lung cancers, it's not as much for cure as it is for palliation. As I said, with the non-small cell lung cancers, oftentimes chemo or radiation will be used to shrink the tumor so that it's able to be resected more easily surgically when they go in there. That is a lung tumor, an adenocarcinoma of the lung. This is the lung area, the tumor area here, but obviously this was a smoker because all that black stuff there is all the tar and nicotine that had accumulated in that patient's lung. What's in your mediastinum? Your heart, your superior and inferior vena cava, and they're all kind of coming. Your superior vena cava, they're all kind of coming into the heart. So if we have tumors growing in the mediastinum, what do you think can be some complications of that? What's that? Decreased cardiac output? Cardiac tamponade. So patients can have palpitations, chest pain, superior vena cava syndrome, where the superior vena cava is compressed or blocked, so fluid backs up into the head and neck. And the treatment for mediastinal tumors is going to be surgical removal if they can get into that area and get it. It's not like wrapped around a major blood vessel or stuck to the heart. Radiation and chemo to shrink and for palliation. So those are your mediastinal, your chest tumors, lung and mediastinal tumors. And now we're going to talk about chest traumas. And the first type of chest traumas we're going to talk about, blunt and penetrating trauma. So what are some of the causes of a blunt force trauma in that patient coming into your hospital? Car accidents, falls. So anytime that, so they're not having the penetrating chest, they haven't had a gunshot or a stab wound, but they've had a crushing injury or, as I said, a rapid acceleration, deceleration type of injury that you would see with motor vehicle accidents. So those blunt force traumas to the chest can be very deceptive. Patients can come in and, they hit the steering wheel and they've got maybe a little bit of bruising on their chest. And, you're focusing on, okay, do they have anything, grossly bleeding and gushing and head injuries and everything else? And all the while, bleeding can be accumulating in that, in the mediastinum or in the lungs and create a real medical emergency. So be very aware of that patient who maybe even walks into the emergency room after a type of accident like that, of the risks and the possibilities of blunt force traumas. What are some of the things that will cause penetrating traumas? Gunshots, stab wounds, bullet wounds, impalements, fun things like that. So the types of things that you're going to be looking at if you're working in the ED is you're going to be looking at how long of time has elapsed since their injury. That's going to help you in your assessment and your determination of how severely injured maybe that patient is and what risks are. The mechanism of the injury. There's specific injuries, including estimated blood loss, if you're able to see any blood loss, and their level of consciousness. And what do you think their diagnostics are going to be? How are you going to diagnose these types of injuries? Chest x-rays. What else? ABGs. What else? CT scan. What's that? Vital signs. You're going to be typing and crossing them for potential transfusions. They're going to need an NG tube, most likely. Why? Right. Well, you also want to prevent any aspiration. If they vomit, then you're complicating the lung issues. Foley catheter. Why? Strict I&O, you want to find out if there's any blood loss, if they're becoming dehydrated or hypovolemic. And a large bore IV so that you can give those blood products. Any questions? But yes. Okay. Basically, you should not be seeing any bubbling in that center. Oh, if the doctor is ordered to have it hooked up to suction, then you will see bubbling. Some doctors won't have it up to suction, and then so this chamber won't even be used. It'll just be the drainage and the water seal. But most of the time they have it hooked up to low wall suction. It should always be bubbling if it's hooked up to low wall suction in that outer chamber, but that middle water seal chamber should not be bubbling. If you see a bubble, that means that there's an air leak. Now, based on what's going on with the patient. No, because I'm going to be showing some more videos. We had a patient that had a small air leak, a little bit of bubbling in the water seal, but when we called the doctor, he said, well, the lung is already re-expanded. We're probably going to pull the tube tomorrow, so just keep an eye on it. And we didn't have to, do any troubleshooting. These particular apparatuses, once they fill up with drainage, you just clamp them and hook a new drainage system on there and toss it in the biohazard. Yes?
So the middle chamber should never have bubbles.
Should not have bubbling at all. Now, you may see what they call the titling, where the level will go up and down. That little ball in the center will go up and down based as the patient breathes in and out, because there's changes of intrathoracic pressure. But many times you won't see that, because if the lung is almost fully re-expanded, you won't see the titling. But you should not see any bubbling in that middle chamber.
Associated with titling.
No, no. Titling is just the moving of the water up and down.
And then one more question.
Yes?
I thought that someone had said that in the pleural space, 25 mLs max.
No, that's what's normally in your pleural space for lubrication.
Okay.
But so it just kind of, I mention that only because when you think about a person who's had a thoracentesis and they've had a liter drawn out, that's, a lot more than what they normally have in that pleural space. And so you can imagine how uncomfortable and how that really affects the patient's ability to breathe.
Not necessarily water, it's more.
No, it's lubricating fluid that the body has in that space, so that and there's another video that I'm going to show you that kind of describes that whole process. So one of the yes.
There's always confusion when to clamp it and when to not clamp it.
You shouldn't be clamping it unless you're disconnecting unless you're breaking that seal, so that air, could potentially go into that tube and cause the lung to collapse again. So if you have to disconnect the drainage, if you find that there's a leak and you have to put new tubing on there, then you need to clamp close to the patient, because otherwise, if you just disconnect the drainage system, air is going to go rushing in and collapse the lung again. But normally you're not clamping the tube. You're keeping the system below the level of the lung, so the drainage doesn't go back into the pleural space. And just monitoring that drainage.
And if you're ambulating a patient, you just take it and disconnect
Yep.
it?
No, you disconnect it from suction, and the patient, just like you take the Foley catheter bag, and you take the chest tube drainage, and usually there'll be like a little hook on there that you can hook over the walker or onto the IV pole, so that goes along with them. So rib fractures, flail chest. Rib fractures can happen they vary in seriousness, but when you have 3 or more adjacent ribs that fracture and actually separate from the rib cage and the sternum and the spine, that's called flail chest. And what happens is that segment of the rib cage, those fractured ribs, it says there it floats freely. I mean, it's not like it's like all over your chest, but what's happening is that it's moving in opposition to the normal movement of the chest cavity. So it's called paradoxic chest movement. What happens is that normally when you inhale, your chest expands. When you exhale, the chest contracts. When you have flail chest, the segment of the flail chest will sink in when you inhale and will puff out when you exhale. So let me pause this, because recordings don't, they take. Pulmonary contusion can happen, oftentimes associated with rib fractures and flail chest. That's bruising of the lung tissue. Sounds like it's just a little bruise. But patients can develop pneumonia, they can develop ARDS, they can be on vents for a very long period of time, and it is extremely painful. So pulmonary contusion can happen as a result of what you just saw in that video for the flail chest. Later. The nurse correlates the administration of warm, humidified oxygen with which rationale? Increase oxygen saturation, increase airway diameter, decrease viscosity of secretions, decrease risk of hypoxia. Can somebody close that door? Okay, 13% increased oxygen saturation, 26% airway diameter, 43% decreased viscosity, and 17% decreased risk of hypoxia. So what is this question? I mean, there's a lot of words in there, but basically what's it asking you? Yeah, why are you giving humidified oxygen? So, and the reason that 43% of you picked, decreased viscosity of secretions. So even though, you know, you're thinking ABCs of prioritization, you'd want to look at, you'd think of maybe talking about oxygen saturation or hypoxia, but you have to focus in on that warm humidified oxygen and why are we doing that? What's the purpose of it? Which client statement indicates that additional teaching is needed about anticoagulant therapy? My gums may bleed some when I brush my teeth. A little blood in my urine in the morning is normal. I need to notify my provider if I see blood in my stool. I should not take any medications with aspirin in them. Okay, 90% a little blood in my urine in the morning is normal. 10% I shouldn't take any medications with aspirin. So what type of question is this? This is like a negative or false option question. So you have to pick the wrong statement by the patient, and that's the right answer to the question. So yeah, they're going to bleed. The gums are probably going to bleed. They should call the doctor if there's blood in the stool. They shouldn't take any aspirin, but not normal to have a little blood in the urine. Which statement indicates the client's spouse does not understand discharge teaching about risk prevention with major abdominal surgery? I will make sure he gets up and walks for at least 5 minutes every 2 hours. I will increase the amount of fiber in his meals every day. I will massage his feet and legs twice a day to help blood return. I will check his breathing rate and level twice a day. So 11% walking for 5 minutes every 2 hours, 17% increasing fiber, 67% massage, 6% check the breathing level. So again, what type of question? Negative or false option question. So should he get up and walk every 5 minutes? I mean every 2 hours for 5 minutes? Yes. How about fiber? Why would that be important? You want to prevent constipation. You shouldn't do the Valsalva maneuver. Checking the breathing rate and level twice a day? Sure. But massaging the feet and legs? No, because he's going to be at risk for developing DVTs, so you definitely don't want to massage those legs. What's the nurse's priority action for the client suspected of experiencing a pulmonary embolism? Increase the IV flow rate, apply oxygen, assess chest and axillary area for presence of petechiae, place the client supine with head and neck flat and legs elevated. 5% said increase the IV, and 95% said apply oxygen. What do you think? Why? Because ABCs. Yeah, he's going to have poor perfusion. At some point, you may want to increase the IV flow rate, but oxygen by mask or nasal cannula is what you need to do. The nurse includes which statement in discharge teaching to reduce the risk for recurrence of a pulmonary embolism? Avoid bending over at the waist, avoid prolonged sitting or standing, apply ice immediately to any site of injury, use incentive spirometer every 2 hours while awake. Okay, 95% prolonged sitting or standing, 5% incentive spirometer. Even though you normally prioritize based on ABCs, does the incentive spirometer have anything to do with preventing the recurrence of the PE? It might have something to do in terms of treatment when you need to improve oxygenation. The nurse notes that each time the mechanical ventilator delivers a breath to a client with acute respiratory distress syndrome, the peak inspiratory pressure alarm sounds. The nurse correlates this with a decrease in which parameter? Respiratory rate, lung compliance, tidal volume, or expired air? Okay, 19% said lung compliance, 62 tidal volume, 19 expired here. Nobody was worried about the respiratory rate. Why? Right, because that's been programmed in. So even if the pressure alarm is sounding, the ventilator is going to continue delivering breaths at the prescribed rate. So we're not worried about the prescribed rate. What does that pressure alarm tell you? What is it warning you? There's increased pressure, there's increased resistance. And when there's increased resistance, what does the ventilator do when it senses there's increased resistance? Well, aside from turning the alarm on, that's telling you that there's a problem, but the ventilator needs to do something. Right, it will stop pushing in the air because the resistance is telling the ventilator you've reached the maximum pressure, you can't push the air in any further. So because of that, lung compliance isn't going to be affected, expired air isn't, but tidal volume is, because it's going to stop before it was able to administer the complete tidal volume that was prescribed. Everybody understands? Got that? You want me? The client is scheduled to have surgery that will require endotracheal intubation and mechanical ventilation for several days post-op. What will the nurse tell the client about post-op communication? You will be sedated and won't need to communicate. I will call the anesthesiologist to discuss your concerns. We will use a variety of strategies to make sure your needs are met. You will have to use gestures to communicate. And 100% of you picked the global option that says we will use a variety of strategies. Because yeah, he will have to use gestures to communicate. That is part of what will happen. But that global option is the correct answer. And now we have a do the math. I know, groan. The patient needs 2.5 milligrams of isoethyrene bronchosol via nebulizer. You have a vial of isoethyrene labeled 10 milligrams per ml. How many mLs do you need to draw up to place in the nebulizer? So what's your desired? 2.5. What do you have? What's your volume? So it's 2.5 divided by 10 times 1. So what are you going to give? 0.25 milliliters. Everybody got that? Okay, good. Okay, we are going to